Welcome to the elective session, Navigating Patient Transition Points Effectively. My name is Dr. Aditi Bustles. I'm here on the Deloitte team, and I am the MC for today's, what I think will be amazingly useful and interesting discussion. I am an epidemiologist by trade who has been working on ways in which we can use primary prevention to reduce poor health outcomes in kids. And so this is a very important topic and near and dear to my heart. And I'm looking forward to hearing from our illustrious speakers on the ways in which they are navigating patient transition points effectively. So we'll start today with an overview of what care transitions look like in PCF specifically, and then I will introduce you to your peer presenters. We'll first hear from Holmes Family Medicine, followed by Northwest Medical Homes on their approach to transitional care management. All right, so I'm excited to discuss several important aspects of primary care today when patients may need that high-touch coordinated care transition of care. And so our goal for this session is to really delve into strategies that can help us improve the continuity of care and, of course, patient outcomes and PCF model aims. So as we know, transitions of care and care coordination can be a challenging time for our patients. It's during these periods that they are most vulnerable to complications, medication errors, and hospital readmissions. We're going to be hearing from two practices and what they do to address some of these things. But before we delve into these specific strategies and tactics, let's take a quick moment to review some insights from our 2023 Care Delivery Reporting Survey. Now you can see on the screen that we can see that over 50% of our practices are choosing to follow up with all patients when they're discharged from the ED, whereas 46% of practices follow up with selected patients or a smaller group of patients that are discharged from the ED. Shifting to our gaze to hospital discharges, almost 70% of practices follow up with all patients post-hospital discharge, whereas 30% follow up with that selected population of patients. These figures reflect, I think, a very strong commitment to the continuity of care, but also it recognizes and shows that practices take different approaches in how they prioritize and manage their patients' needs. That is why we are very excited that today's presenters represent an independent rural practice, as well as a practice in an affiliated urban practice. And it's important to understand that approaches to effectively managing transitions of care can look very different based on the context of what the practice is in and the types of populations that they serve. So without further ado, I'm going to turn it over to Gillian, Misty, and Viet to introduce themselves and their practice. Gillian, let's start with you.
Sure. So I'm with Holmes Family Medicine in Millersburg, Ohio. We have about between 10 and 11,000 active patients on any given look-back day. And this also includes our OB patients. So we're a pretty busy practice. About 10% of that is over 65 years old, and about 12% of our population is with Medicare as well. As far as my background, I actually started out in occupational therapy and made an unexpected switch over to the administrative side of things, but it's been about 6 years that I've been with the practice and in managing all of our quality and value-based programs now. So PCF was a natural continuation for us as we continue to evolve with what is changing as things change through healthcare. And that's about it for our intro at the moment.
Well, thank you. We can pass it to Misty.
Hi, good morning. My name is Misty. I've been with Northwest Medical Homes for about 2.5 years now. We're a practice that's in Springfield, Oregon. And we have a pretty big practice. We have 3 different clinics that patients are seen in, urgent care, just all kinds of good things for our patients.
And last but not least, Viet, we'd love to hear from you and hear a little bit about yourself.
Definitely. My name is Viet. I'm the director of pharmacy here at Northwest Medical Homes. We serve about 30% of Medicaid, 30% of Medicare, and 30% of commercial patients. We slightly have a little bit more Medicare patients now, though. Older patients needing a lot of help from us. I have been with the organization since 2021. and I've been helping with the TOC department since last year, working with Misty to co-manage the TOC department, transition of care department.
Well, thank you all so much for your introductions. And we now, before we jump in, would like to hear from everybody that is in our session. We are going to put up a poll, and we'd like to know, how often is your practice notified that patients are being admitted or discharged from the hospital? So just take a moment and fill that out for us so that we can see where you all are at. All right, so it's coming in real time. So I'm going to read out some responses. About 70% of you are saying every day, and about 20%, 22% are saying continuously, so as patients are being admitted. And then about 5% of you are saying weekly. So very interesting, and I think that speaks to some of the data that we covered earlier, that our practices are really addressing the needs of patients in different ways, and there are different processes in place that could potentially change the context in which you are adopting some of these strategies and practices for care coordination. All right, well, we will go ahead and jump in. We'll start with Gillian, and we'd love to hear a little bit about your practice's approach to transitional care management.
Yeah, sure. So I think on the next slide there, it kind of outlines the highlights of our approach. Obviously, there's a fair amount of work involved with each of these stages, but really it starts with, as that first step brings out, identifying the patients that we have that are going through these transitions in their care. So we really feel that this is the most impactful part of the process, because if you don't know, then you can't be actionable with your patients who are going through these transitions of care. So our primary feed is through our regional HIE here in Ohio. And so it is in real time, but we have to go get the data. So we do that at least once a day, if not a second check, depending on how our day is going in the office. And we also support that data and cross-check with other sources as well, such as our relationships with our local hospitals, as well as any claims that are coming through on our payer platforms and portals. And we also have another ADT feed that runs through our ACO. So we're not checking all of those every single day, but we try to a couple times a week, just to make sure that we're getting a complete picture and we're not missing, because even with all of that, we will still miss some patients. It does happen. I'm always amazed at that. But we're trying to get as complete a picture as possible of who is going through this transitional period in their care. Then the next piece is really to get a better idea of what is going on before we reach out to them. This serves a few purposes. We're not going to be reaching out to patients and their families who don't need a transition of care from us at the time, for example, if they've been discharged to hospice. So this helps us identify those patients when we get this additional information. And also for our patients who we are following up with, which is the bulk of them, we are able to know what additional or what other things we need to cover in conjunction with the templates that we use, such as, is there equipment that hasn't been gotten yet? Is there home health that they haven't been followed up with yet? New medications, things like this. So we like to be prepared as prepared as possible when we reach out to our patients, so that we can make the most of that touch that we're getting with them. And here again, just like how we identify our patients, we really try to use everything that we have at our disposal. So depending on the speed of the facility that they've been discharged from, we may already have some of these discharge or ER report documents in our EMR that have come through our medical records department and have been loaded into the chart. So that's ideal. But it might not be there yet. So we also use the patient view portion of our HIE to see if any documentation has been posted on that platform, as well as we can look at those other items in the ADT feed, just to even get some, those data stamps from it, basically. We also have some shared logins with a couple of our local hospitals. So if we are really struggling with trying to find things, we will go and search there. And of course, if we really can't get anything, because we of course have our hospitals that just are not great with sharing information, we all know that struggle, then we're going to send out requests and try to get them as soon as possible. With the information that we have, we usually try to make a judgment call on how quickly that patient needs to be reached out to help them manage their care transition. So if we can put it off for a little bit until we are getting that documentation, then we will. But if it's taking too long, or we're just maybe never going to get it, we will still reach out to that patient with the information that we have, even though it's incomplete, because the most important thing is to help them to manage that transition at that time. I believe the next part then is the actual outreach. So there's all the prep time that we do, and then there's actual outreach. So our care manager nurse at our office, we have one for our whole office. She is responsible for the outreach to all of our patients who are discharged, specifically who are discharged to home, and not including our OB patients. We have a separate process for that. So we follow the 2 business day guideline for inpatient discharges, and also the 7-day guideline for ER discharges. The number one goal of our outreach is always to prevent our patients from returning to the ER or from returning to an inpatient setting. So we use our templates and our questionnaires within our EMR as a guide for that conversation, and to go along with whatever those unique needs of each patient are. Our questionnaires and our templates that we use includes things like concerns since their discharges. Are their symptoms improving? What was their original complaint or issue? Is there follow-up care needed or recommended? Education on the care that we can provide for acute needs, discharge instructions, home health or DME status, medication reviews, scheduling their TCM or ER follow-up appointments as they are needed. So it covers a lot of different things. And then, of course, each patient is unique. So we're filling in as we go, and not every single question applies to every single patient. But this is really our starting point for having that conversation and hitting the things that are going to have an effect on whether or not we can keep them out of the ER or out of the hospital. And I want to point out here, we really feel that a strategy for success in this area, in conjunction with the outreach, is maintaining schedule availability for ER follow-up appointments, and also TCM and inpatient follow-up appointments. We often think of keeping acute appointments open on the prevention side, which of course is very important. We do keep our acute appointments open so that we can get patients in the office instead of in the ER. But also on the flip side, we really also view those acute appointment slots as being critical to this follow-up process, so that our patients who have been in the ER or have been discharged from the hospital can get in a timely manner to have those follow-up needs and transition needs taken care of. And probably the least exciting part of this, but a very crucial part, is the tracking portion of the follow-up process and the transitional care process. So for us, and this will be unique to everyone's ADT feed that they can get and unique to their EMR and just software setup, the way our ADT data presents, we have to log in and go get it. And we then copy it out of the HIE platform and copy it into a spreadsheet. It's very basic. But we use that spreadsheet and keep building on it throughout the month. We start a new one in each month. And so that's really a centralized communication tool, primarily between our care manager nurse and myself, to keep up with what is going on with all of our patients who are discharged and what are their various follow-up needs, where are we at in the follow-up process with them, in addition to, of course, documenting things in their chart. So we're putting things in there like whether or not the outreach is completed, their appointment is scheduled, we left a voicemail, whatever it is that is keeping us on track with that process, it's going in there. I also keep an eye on it because it does become a nice tool to track our patients who have been admitted to the hospital or who are in a skilled nursing facility for now. And also we can use it as kind of a, how did I describe this? Our in-house resource to figure out if there's any trends or anything specific going on with our patients in real time. So we're not waiting for claims data to come back. We're not waiting through that process. While that is important and we do that, but when we need to, when we want to, we can jump into our spreadsheet and we can sort it. We can, filter the OB discharges out of it and look at just our actual acute inpatient discharges. We can filter it down. We always keep track of our patients' insurance. So we can filter it down and look at what's going on with just our Medicare Part B patients and see if we have any frequent utilizers or other trends that are going on that maybe we can be actionable with and jump in and do something about it. So the tracking is definitely not the most glamorous part, but it does provide some really important insights and just the ability to share the work and get what we all need out of it. Did you have something there, Aditi, or do you want me to just talk about this slide?
Important to talk about impact. I think that's one of the first questions that folks that may not necessarily be completely bought into some of the different processes, strategies, and tactics want to know is, what difference did you make? And I think the decrease that you see here is pretty incredible. So would love for you to speak a little bit about how you all were able to see this decrease and any thoughts or ideas that you have for if someone wanted to implement or adopt some of the ways that you have been doing care coordination, what they would really want to focus on.
Yeah, sure. So this graph is a graph that we love at our practice because it took us a really long time to get here. So while we've seen this decrease in the past 6 months or so, and again for Q2, our PBA that we just got, which would be Q4 of 2023 data, we decreased again down to 0.71 in our AHU. So that it's continuing to fall, and it's not just a fluke either. The data shows that it's a statistically significant decrease that we're having. So that's giving us confidence that we are having an impact on our processes are actually finally having an impact on results. So being patient has been key. We did CPC Plus before this, and we really never moved the needle the whole time. But as we've continued to hone that process and really refine it and make it work for our practice, we've started to see these results. And that's really the big thing that has been great with PCF is, as a small independent practice, having the flexibility within the care delivery objectives and requirements and being more result focused has helped us to be able to adapt these different workflows and make them work for us because not everything fits every practice or every patient population. So again, we really feel that the biggest impact is just getting the data to start with, because you can't do something with what you don't know. Mm-hmm. And so early on when I started with the practice, we made the switch to using the ADT notifications from our HIE. And while that was really overwhelming at first, because suddenly we had all of this data and all of this patient data, and we had to figure out what to do with it, that was such a big first step in being able to see what was really going on. Because of course we have our responsible patients who will keep us up to date with what's going on with their care, but not everybody knows to do that. And so we've slowly also just been training our patients to be more in connection with us and keep us up to date with what's going on with their care so that we can be there for them at those points where we can fill a need and fill a gap.
Well, thank you so much for such a great overview of your processes, and really appreciate the emphasis on the data-driven decision-making and how key that is both in the beginning and throughout the process of adopting some of these practices. So that's a great segue to hearing from Misty and Viet about some of the work that they are doing and how they may be leveraging ADT data from their HIE. So I will pass it over to them to talk a little bit about their work.
Hi, let's see here. So in our transition to care department, we get a spreadsheet or information from a system called Point Click Care or Collective Medical. So it downloads a Excel spreadsheet every morning and lets us know what patients we have admitted, what patients are in for an emergency room visit. So we have a team of 5 that goes through the list and creates telephone encounters with our specific templates of what information that needs to go in there. If it's a hospital inpatient, we have a separate area that we keep those in our system that we go through daily, because we cannot rely on the information that we get from collective medical every day as to, even if they notified us of an inpatient, they don't always notify us of the discharge. So we finally made some ways that we can collect all that data, keep it, and then also making sure that we're getting the patient their discharge information to the provider, and sending it off, and then calling the patient and getting them scheduled for their follow-up appointment. So we collect a lot of information from the point click clear, and then we just work off of those screens and telephone encounters to get that done effectively. Let's see, what else do we do? We kind of have a big process. We have separate telephone encounters for our patients that are discharged to the skilled nursing facilities. We have telephone encounters in our own box for our ED patients. So we're keeping track of all of them, making sure we have access to records to all of our local hospitals, plus some of our outside hospitals outside of Lane County, that our patients are sent to. So it makes it easier for us to be able to get the information for the providers when the patient is discharged to put in the chart, or even if they're not discharged yet and the provider is like, hey, what's going on with this patient? We have easy access to get there. What else do we do? So we also do 3 points of outreach to the patient. We outreach to them within 24 hours of discharge. Our first outreach is via a messaging system called Clara. It's a HIPAA compliant text messaging system. So we'll reach out to them first by that. If we get no response from them, then we do a telephone call, saying, hey, how you doing? We know you're in the hospital. Your provider would really like to see you. Let's get you scheduled. And all of our providers have 2 hospital follow-up spots on their schedule to see a discharged patient. So the patient's not waiting out for months to get in for that 0 to 14 day time frame, which is super helpful, because some of our providers all of our providers are super busy. So it's nice to be able to have that spot just to, put a patient there so that they can get in and be seen. So that's the telephone call. And the last thing that we do to outreach to our patients is we'll send a letter. So if the text messaging doesn't work, the phone call doesn't work, then we send a letter saying, hey, your provider really wants to see you. And then we also have a direct number for them to call us back via with the Clara message, or even our phone number. Our TOC team has their own number that patients can call and directly get scheduled, so they don't have to go through our main switchboard and do scheduling through that. Let's see. I think that's about it for our TCM outreach.
So after all of that is done, the TOC team would have done the groundwork for the pharmacist to do the next part, which is the medication reconciliation part. About a few years ago, we had non-pharmacists doing these medication reconciliations. And then when in about 2019, we started having pharmacists at our organizations, and we thought, well, who would be a better person to do medication reconciliation than pharmacists? So that's when we started joining the whole process. So when we call it a telephone encounter. It's basically a messaging system we use for eClinical works. When we get the TE or telephone encounter, we will take a look at the patient discharge summary to see why they got into the hospital, what has been done in the hospital, and what they got discharged with. And we use the discharge medication list that the hospital provided, we would compare that to our current medication list to see if there's any discrepancies, to see if there are any medications that have been adjusted, to see if there are any new medications that we need to add to our system. The goal is when the patient sees their primary care provider, the medication list would be up to date. So the provider wouldn't have to spend time updating the medication list. Rather, they would spend time checking on the patient and focus on any new acute problems if they arose. For the medication reconciliation part, sometimes what we do for the pharmacy team is we call the pharmacies to clarify whether the patient picked up the medications or if they had any problems with insurance. We would try to help navigate that process for the patient on their behalf. And we also double check to make sure that the medical history is accurate, the surgical history is accurate. So whatever we can do to update the patient's chart for the provider, that's what the pharmacists are doing to help kind of tidy up everything and get the patient ready for the provider when they see the patient in office. Another side project that we do that we look at is also we look at the lab results. For example, if the patient got an A1C in the hospital, we make sure we push that in our chart. Or if the patient got a urine culture, a blood culture in the hospital, we want to make sure that the antibiotic that was given will be effective based on the culture results, based on the susceptibilities. So those are a few examples that pharmacists can help with, not just the medication part, but also the lab review and also the coordination part based on the chronic disease problems that the patient has. So let's say we have a patient who got admitted for a DKA, a diabetic ketoacidosis, and their A1C was over 10%. So when the pharmacist does the medication reconciliation, they will we call it a block on our schedule. When the patient comes in to see the provider, we kind of come in, provide some education, and ask the provider if they would need our help managing the patient's insulin, for example, or if they needed us to provide some education on diet, we could do that too. Another example is the patient got admitted for an acute exacerbation of their COPD. What we could do in office as a pharmacist is we could help provide education on how to use their inhalers properly. Another thing that we do is create an action plan in case they have another exacerbation. What would they do? So those are the things that we kind of help tailor care for our patients with chronic diseases. The goal is to prevent them from going back to the hospital. Besides the things that we do as the pharmacy team, whatever the provider thinks would be best for the patient, we would try to help out. If their inhalers are too expensive, we would also help to find out how we could get them inhalers for a cheaper price. That's another example of how the pharmacy team can help patients get the medications that they need. And looking at the graph, we started the whole process in 2018, 2019, and we had a lot of changes since. Since 2022, this is when Misty took over and kind of created a more detailed process for everyone. And about the same time, 2019, 2020, the pharmacists got involved. So you could see a decrease in the number of observed admissions over the number of expected. We're happy to see that the progress that we have made and also the changes that we have made have helped our patients to have a less number of admissions compared to, let's say, 3-4 years ago. The process that we have right now, we every day, every month, every week, we try to be a little more creative and think of ways how we can make it better, how we can update the charts better for the providers, how we can provide more tailored care to our patients. Again, the goal is to prevent them from going back to the hospital. So however we can help, we would like to help them out.
Yeah. And, when we did ask you all what you think contributed to such a substantial decrease, of course, you all mentioned the Transitions of Care program. And you all have touched on a couple of things, I think, that I want to bring back up for the audience. One is that consistent communication, those 3 points of contact to make sure they get into the practice to prevent, future readmissions. And then, Viet, you talked very very in depth about the different ways in which your pharmacists and your pharmacy care team really are a crucial part of care coordination and helping kind of fill some of those gaps as it relates to either the patient's chart or their medical history or things that other providers within your practice would need to know in order to provide, that best care. Any other ideas or thoughts as to why your transitions of care program has specifically, you think, led to this decrease in your AHU score? And that's to both of you all.
I think just being, I don't know, Viet, what you have to say, but, just being persistent and making also that connection with the patient, letting them know that, hey, we have this special team that is, reaching out to you on behalf of your provider, and knowing that, the provider really does want to see them, does care about them, does want them to come in. I mean, we get patients that call us back, even if it's not for, the admit appointment that they need, asking us for, other things, or can we help them get, some of the stuff that they weren't discharged on the hospital with. So I think just being, letting the patient know that we care, I think helps a lot.
I think another reason I could think of is the coordination between the behavioral health team, the pharmacy team, and also the TOC team, and of course the medical team. So it's a collaboration of everyone, and also the continuous improvement process that we have. We have a process that's working, but we also trying to find ways to improve, to make it better, to make it more effective, to make it more convenient for everyone, not just the TOC team, but also the providers, how we can make them be more efficient when they see the patients for follow-ups. I would say it's multifactorial. It's a lot of things that we have put together to try to help our patients out. It's hard for me to pinpoint out one thing that would actually has made a big difference in our number of observed admissions compared to expected.
Yeah. And I mean, I think all of those things have contributed. And it sounds like you all have been very thoughtful in terms of incorporating all of these different pieces to make sure that the patients are getting the best experience possible, and their care is well transitioned from different settings. Well, I want to thank you all and Gillian for providing us such comprehensive overviews. We will move into our question and answer period. So I encourage you all, those of you that are listening, we have over 90 of you, so I know you have questions. Feel free to drop those in the Q&A section, and we will try to get to as many of them as possible. But I'm going to open it up to the whole group. And one of the first questions that we got was, where do you see the biggest impact that comes from these transition of care calls? Is it doing MedRecs with their discharge meds or something else? And I will open that up to the group. Maybe Misty, we can start with you.
Sorry, I was reading some of the other questions over here and I didn't hear what you asked. I apologize.
No worries. The question was, where do you see the biggest impact from these transition of care calls?
I mean, not everybody answers the phone. Sorry, I don't really know how to answer that.
That's okay. Viet or Gillian, any thoughts there in terms of impact?
I would say for us, Misty mentioned something earlier about just establishing the contact with that patient. And so I don't have any data on this about, how each portion of that follow-up process is impacting our patients. Some of them may respond more to their actual appointment with the physician. Some of them may respond more to that med review or another follow-up call after the appointment or what have you. But establishing that connection and making it clear that this is a two-way street, this is an open line of communication in this vulnerable time in your care, makes it much more likely for them to reach out to us when they need something. And it also creates some accountability too. We have noticed, just anecdotally, our patients seem a little more likely to go see that specialist that they're supposed to go see, or to come in and keep their follow-up appointment with us as well, because they know that we care about that and we're keeping track of that and staying on top of it.
Anyone else have anything to add yet?
To piggyback on that, a lot of the times what we find is that we find out problems that the patient is experiencing and we can help them out. For example, they didn't get their prescription because the hospital didn't prescribe, for example. So our providers could help prescribing those, or they couldn't afford the medications, for example. That's something we could help out also. Besides making the connection, also trying to find out what is stopping them from getting the care that they need so we can help triage and navigate for them.
We had a lot of questions come in about the role of the pharmacy care team. So I'm going to try and combine some of them and maybe open it up to all of you. One question that came in was, do the pharmacists provide other care services beyond, some of the things that you mentioned for the patient and caregiver specifically, Viet? I'll throw that to you real quick and see if you can answer that for us.
For sure. So medication reconciliation is just a small part of our daily workflow. Mainly what we do here is we help providers manage chronic disease states. We have collaborative practice agreements for pharmacists to manage. We have 6 of them: diabetes, high blood pressure, high cholesterol levels, COPD, asthma, smoking cessation, oral contraceptive, osteoporosis. So those are the ones that we have currently. We're working on getting more. We have a residency program here where we train a second-year pharmacy resident to do clinical work at the primary care setting. So that's helping with everything that we are trying to build. And we help providers doing those visits so that they can focus on more acute visits. Mm-hmm. Another thing that we do is we help with the annual wellness visits. We help provider conduct these visits and also provide screenings to patients so that providers can come in and focus on more acute problems rather than the preventive problems that the patient has. What else do we do? We do a lot of consultations either in person or either over, we use Teams or also over the phone. However, it's more convenient for the patient. On a daily basis, I get calls asking, for example, this patient got a weird bug in the urine. What should I prescribe? So that's one example. A lot of the times that's what we do. And then between visits, we do medication reconciliations. Another service. I'm sorry.
No. Please go ahead.
Another service that we provide that I think is helping our patient is to remind them to pick up the medications. Mm-hmm. A lot of our patients are really behind on their refills, and we get notifications from the insurance company saying this patient filled a 90-day supply 4 months ago. We don't know what's going on. So we call them, we remind them, we call the pharmacy on their behalf too. Maybe it's a coverage problem. Mm-hmm. So we think of us as the backup dancers for the providers here, however we can help. And also metaphor. For the patients.
Love that metaphor. Well, a follow-up question to that is, of course, for those that want to incorporate this practice of using pharmacists in the transition of care management process, there certainly could be some pushback because you all do generate revenue for the system. Was this something that came up when you were creating your, model? And if so, how did you address maybe some of that pushback?
Definitely, because pharmacists are expensive. And how do we pay for ourselves? So what we did was we looked at a few studies out there, how incorporating pharmacists in a primary care clinic has helped patients in terms of quality metrics, in terms of outcomes. And we have presented that in the past to the partners here. At first, of course, they were very suspicious about what could a pharmacist do to help out. And then over years, we looked at the quality data. We looked at the blood pressure data, A1C data. Another service that we provide is we call patients weekly to do insulin titration over the phone. So we help titrate up their insulin to make sure the blood sugars are at goal. So when we looked at the data, we did see that for the patients that worked with the pharmacists, their A1C went down from 9% to less than 7%, let's say, for an average of 6 months. Mm-hmm. And then the providers would see the reimbursement from the Medicare services that we met the quality metrics because we had pharmacists helping us with that. And that goes the same with blood pressure. And then the AWV visits that we help out, those would count too. And then slowly the providers would start seeing the value of the pharmacists. And then also another thing is that they didn't have to look up things. They didn't have to spend time looking things up anymore. They could ask their pharmacist for a a recommendation. And that saved them a lot of time. So that would turn out that they could see more patients, more acute visits, more money. It's a little bit iffy in terms of the actual money that you put on the pharmacy services, but you could try to find ways to convince your providers, maybe starting out with one pharmacist and go from there.
It's a great point. Gillian, Misty, any additional thoughts on the role of pharmacists in transitions of care plans and management?
So we don't really have, the same resources, obviously, being an independent practice. There was a brief time we were so close. So if you do have a resource like this in your community as an independent or rural provider, jump on it and take advantage of it before you lose it. But we had a local pharmacy that was willing to work with us on a contract basis to be a little more involved in our MedRec process and into that consulting role for us. Unfortunately, like what happens, even to many providers too, they got rolled into a larger pharmacy system. And so we never were able to really take advantage of that and make it work. But if you do have something like that, definitely take advantage of it, because we were very excited about it at the time, but we never got to make use of it really.
Yeah. And I think, I want to bring up the point again that we are hearing from two practices that have very different contexts. But as you all saw in the slide presentation, both saw a substantial decrease in their AHU scores, right? So what resources that, Northwest may have, Holmes may not have, but you have different really important strategies and tactics that have worked to help kind of improve that care coordination process and ensure that patients during such a vulnerable time have a very seamless transition of care. And that actually brings me to my next question. And I think this is one that I'm sure you all have examples of, is what are some kind of impactful or inspiring stories, patient stories that you may have or have come to top of your mind as it relates to successful transition of care management?
We have a patient, I had mentioned before that we have a direct line for our TOC or TCM management team. And there's one patient in particular that will just call us directly for everything. If he needs supplies for, from a supply company, he'll ask for me or one of the other TOC members who's an MA to help with those supplies. We have other people that call and, let's say, I'm having a hard time with this. Can you help me with this? So I feel that, that's impactful in a way that they feel comfortable with asking us to help them with things in our TOC department. And then also, if we're not able to help them, we, make it happen to get what they need, so that they don't feel like they're being left behind or anything like that.
Yeah, similar to Misty, just thinking about some of our different patients. Some of my favorite examples too are patients that we'll reach out to for TCM purposes, and then we get into other stuff on the phone at the same time too. So any point of contact is a valuable point of contact. Some of them are going to be really quick, like, hey, we just wanted to make sure that you're doing fine or your kid is doing fine because it was something pretty simple, but we're going to double check anyway. And then some of them turn into a much bigger thing. But we are opening up that door. And, some of our more complex patients, especially, it's really just keeping them tied to the office and providing that link so that we are there for whatever they need.
Yeah, there's another question coming in for you about other ways that, the pharmacist role can be utilized. But a specific question was, what resource do you use to obtain information on medications that may not be picked up?
So another pharmacist on my team, what she does is that she will get reports from the insurance companies on patients who have been behind on their refills, and we call it telephone encounters for the pharmacist or whoever is available, mostly the pharmacist, to call the pharmacy to find out what the holdup was. And also we would call the patient to educate on adherence and also find out why they didn't pick up the medication to help triage. And also what we do is when we look at the labs, or we'll look at the last office visit to see if the patient was seen for a diabetes check a year ago, we would try to schedule them until. So based on the summary that we get from the insurance companies, we try to navigate and triage and help patients out in order for them to come in if they need refills, for example. So however we can do to help them get their refills on time and provide some education as needed.
Thank you for that. So the last 5 minutes, I'm going to open it up to all three of you and ask if there was one thing, one lesson that you wanted folks listening today to take back with them as they think about their transitions of care plans and management system, what would it be?
TOC, TCM, it's always a work in progress. You're never going to find your perfect way of doing things. And I think the biggest thing to take away is, know that you're getting the patients what they need, number one, and you're getting their providers what they need. And then just focusing on or thinking outside the box on how to improve your TCM or, how to make things better. I'm constantly working with my team, asking them, hey, we did this and we did this, what's going to work better for you? So it's never going to be perfect, and it's always going to be a work in progress. So just know, and you already know your patients are getting good care.
Love that.
Yeah, ditto to what Misty said. It is always changing, and we've changed it so many times. And each patient is unique, so it's going to be a little different for each patient as well. Our guidelines and our templates that we use are really just a starting point. But, and I do tend to harp on this, but getting your data right is so huge because and in whatever aspect, Viet talked about, non-compliance with medication fills too. That's another huge point for getting your data right, because if you don't know that it's happening, then you can't be effective or be actionable with any of it. So that is, I think, the number one for me. That's the number one place to start, because without the data, you're not doing any of the rest of it.
Right. Correct.
I think my takeaway is very similar to what the previous two just said too, is the continuous improvement process. Be open to feedback. We get a lot of feedback from our providers and the TUC team members on how we can improve. And the more feedback we have, the better our workflow would be, in my opinion. So we take feedback pretty seriously and see how we can help improve the process further.
Well, I want to take a moment to thank the three of you for such a, thoughtful presentation. It's very clear that you all are very passionate about making sure that we are consistently improving our healthcare system to provide the best possible care. I also especially appreciated hearing about some of the ways that you've made an immediate impact in terms of both the patients and your colleagues within your practice. And I hope that those that are listening today are able to take some of the strategies and tactics that you all shared, both in an urban and in a rural setting, and apply it to their transitions of care plans and management processes, because I think that there is a lot of great information shared. That being said, we have more information that we can provide to you. There is a resource that we have popped up on the screen for you all that talks about some of the transitions of care management resources that could be helpful as you start your conversations or are continuing some of your conversations to continue to improve the ways in which you're providing care. And that is available here. And then, of course, if you have any questions that arise as you are digesting this great information, we recommend that you reach out to us at the PCF Practice Network email that is readily available throughout this conference. And then last but not least, as we continue to create more resources and learning events for you all, we would greatly appreciate if you'd complete this short survey. It really helps us in ensuring that the information that we are giving you all is relevant and timely and useful as you all are seeking to improve primary care. Thank you all for being here, and we look forward to seeing you at the next session. And thank you to our speakers again for all of their great work on today's panel.